Welcome. Thank you for joining us today. My name is Dr. David Wong. I'm a pediatrician and medical officer with the Office of Minority Health at the U.S. Department of Health and Human Services. We're very excited to be presenting a webinar today titled Sickle Cell Transitional Care from Childhood to Adulthood, the Role of Community Health Workers. As many of you know, September is Sickle Cell Awareness Month, and this will be one of a series of 3 webinars that our office will host over the next 6 to 9 months. Before we get started with our speakers, I just wanted to go over a few housekeeping items. First of all the participants will be automatically muted throughout the duration of this webinar. If you have questions, we ask that you submit them at any point during the webinar via the chat box. After both presenters have given their talks, we will try to answer as many of the questions as possible. This webinar is being recorded. You'll receive an email after the webinar, which includes a link to watch the recording. Unfortunately, slides will not be available, but if you would like more information about the links and resources, please email the organizers of this webinar. I'll start by introducing our first speaker. Her name is Ms. Mia Morrison. She's a project officer with the Sickle Cell Disease Newborn Screening Program at the Maternal and Child Health Bureau of the Health Resources and Services Administration. Thank you, Mia.
Thank you for the introduction, Dr. Wong. So I am a project officer in the Division of Services for Children with Special Health Needs and in HRSA. And HRSA's mission is to improve health and achieve health equity through access to quality services, a skilled health workforce, and innovative programs. We have 2 programs that specifically focus on sickle cell disease. One is the Sickle Cell Disease Treatment Demonstration Program, and the other is the Sickle Cell Disease Newborn Screening and Follow-up Program. Next slide. So sickle cell is the most common genetic blood disorder in the United States. It impacts the body's ability to make enough healthy red blood cells. The red blood cell can take on a crescent shape and hinder blood flow to the body, causing a lack of oxygen to organs. People who have sickle cell experience pain, fatigue, organ damage, and a range of other health complications, including premature death. It used to be considered a childhood illness, but life expectancy is increasing. Sickle cell disease includes sickle cell anemia, which is hemoglobin SS. It also includes hemoglobin SC and S-beta thalassemia plus. Hemoglobin SS is the most common sickle cell disease and the most severe. Most people with sickle cell disease are Black or African American. However, babies of all racial and ethnic backgrounds can be born with sickle cell disease if their parents have the gene. Next slide. Sickle cell is caused by a mutation in the hemoglobin beta gene found on chromosome 11. It's an autosomal recessive disorder, meaning you need 2 copies of the abnormal gene to have the disease. The normal gene is expressed as A, and the sickle gene is expressed as S. If you have 2 copies of the gene, so SS, that means you have sickle cell anemia. If you have 1 copy of the gene, or AS, your health will be for the most part unaffected, and you will hear that called sickle cell trait. Both parents must have the trait for the baby to be born with it. So for example, for a child of 2 parents that have trait, there's a 25% chance the baby will be born with sickle cell disease, a 50% chance the baby will have a sickle cell trait, and a 25% chance that the baby will be born with normal hemoglobin. Currently, all states have newborn screening implemented for sickle cell disease. Next slide. So what is sickling? So red blood cells are produced in the bone marrow, and inside the red blood cells is a protein called hemoglobin. Its job is to help red blood cells carry oxygen around the body. People born with sickle cell disease have abnormal hemoglobin, which causes structural and functional problems with the red blood cells. Healthy red blood cells are round and flexible and can travel freely throughout small veins and capillaries. Sickle cells are rigid, sticky, and crescent-shaped. This causes them to get stuck and block small veins and capillaries, and as a result, block or reduce the amount of oxygen that gets to tissue in places like the lungs and other parts of the body. Typical healthy red blood cells live for between 90 and 120 days before they're reabsorbed by the body. Sickle cells only live for 10 to 20 days. The body just can't keep up with the production. This lack of healthy red blood cells can cause organ damage, slow growth, delayed puberty, and numerous other health problems. Next slide. Just to provide a brief overview of the epidemiology in the U.S., we don't know the exact number of individuals living with sickle cell. However, current research indicates that sickle cell disease affects about 100,000 people in the United States. The CDC reports that 1 in 365 Black or African American babies is born with sickle cell, and that sickle cell also occurs in 1 in 16,300 Hispanic births. 1 in 13 African American babies is born with sickle cell trait. It's important to note that anyone can be born with sickle cell. However, it's most prevalent in this country among Blacks or African Americans. Next slide, please. This map shows an estimated distribution of sickle cell across the United States. As you might know, sickle cell is a complex disease, and it's exceedingly important for individuals to not only be linked with specialty care, but also primary care and other subspecialists that can monitor and treat other factors, for example, conditions associated with aging. For individuals with sickle cell in rural areas, it can be challenging to find an adult provider who's trained in the evidence-based guidelines. Also, many individuals with sickle cell access health care through Medicaid, and it can be difficult even in larger metropolitan areas to find doctors accepting new Medicaid patients and who are well-versed in the evidence-based guidelines. In general, many people with sickle cell disease face barriers accessing the recommended care and other health resources. Next slide, please. So this diagram shows the different acute and chronic health complications brought on by sickle cell. Not only do individuals suffer from pain, but they can also present with other adverse health conditions like swelling in the hands and feet, retinopathy, leg ulcers, stroke, neurocognitive issues, and pulmonary embolism. In the interest of time, I'm just going to talk about a few. Next slide. So vaso-occlusive crisis or pain crisis is caused because sickled red blood cells can block flow to tissue and organs. Pain is very common and is one of the most frequent reasons sickle cell patients seek care in the emergency department. The pain can be extreme and anywhere in the body, and it frequently requires treatment with opioids. Pain gets a lot of attention, but it's just one of the many adverse medical conditions that individuals living with sickle cell experience. Acute chest syndrome is a life-threatening condition and a leading cause of death for people with sickle cell disease. Symptoms include fever, chest pain, and shortness of breath. And individuals with acute chest can get worse very quickly. Acute chest syndrome can be brought on by many conditions. For many adults, it's the result of bone marrow or fat embolism and infections or asthma. Possible treatment for acute chest can include administering oxygen, red blood cell transfusion, hydration, and medication to control pain. Next slide, please. Fever is also very serious and should be treated as an emergency because it could be a sign of a bacterial infection. In general, people with sickle cell disease are more susceptible to infection, particularly from encapsulated bacteria. One of the major reasons is due to splenic function. In sickle cell disease, the spleen can become enlarged with red blood cells that are either trapped or that are being actively removed by macrophages. Splenic sequestration can lead to a rapid drop in red blood cells in circulation, leading to severe anemia and is a medical emergency. Due to frequent crises involving the spleen, sickle cell patients can lose the function of their spleen at an early age. So, for example, it's part of the evidence-based guidelines that all children under the age of 5 and older children who are at higher risk for infection take penicillin to prevent infection. Next slide. The good news is that because of interventions like newborn screening, utilization of penicillin prophylaxis, medication like hydroxyurea, and other strategies used to manage sickle cell from an early age, people living with sickle cell are living longer. You can see from this graph that many children will live into their 40s, 50s, and beyond. Next slide, please. This list provides some examples of the way that sickle cell is managed. For example, in childhood, it's extremely important that kids receive annual transcranial Doppler scans to assess for risk of stroke. As mentioned previously, children should also be on a regimen of penicillin prophylaxis. People of all ages may need transfusions. All individuals with sickle cell should ensure that they're drinking enough water because dehydration can put a person at greater risk for a sickle cell crisis. It's also important that people of all ages are working with their care team to address pain with opioids, other techniques, and pain-reducing drugs. There are 2 FDA-approved drugs used to treat sickle cell. One is hydroxyurea, and prior to July 2017, hydroxyurea was the only FDA-approved therapy for sickle cell disease for over 20 years. Its use is supported by hematologists and the NHLBI evidence-based guidelines. It's approved for use in adults and children, and it works by increasing production of fetal hemoglobin, which does not sickle and survives longer in the body. It's been shown to reduce hospital admissions, pain crises, and acute chest syndrome. Another drug that I want to highlight is Endari, or L-glutamine, and this is approved in July 7, 2017. It's FDA approved for adults and children, and it works by improving flexibility of sickled red blood cells. Next slide. Unfortunately, not all individuals with sickle cell are able to access care in accordance with the NHLBI guidelines, and many face challenges accessing and taking hydroxyurea. Some of the barriers identified include patients and providers having a lack of knowledge of hydroxyurea, the requirement to have frequent monitoring to assess the body's response, lack of adherence, providers having a lack of knowledge and comfort with treating individuals with sickle cell disease, and care being provided in a setting where patients and families are not partners in the decision-making process. Community health workers can support individuals in overcoming barriers to accessing drugs like hydroxyurea by providing interventions such as education and care coordination. Next slide. Due to the medical advances I just discussed, recent studies have demonstrated up to a 98.4% survival rate to 18 years of age, and individuals are living longer and longer. However, for a variety of reasons, which I think are going to be covered in more detail in the next part of the webinar, young adults are at higher risk for hospitalization due to illness and pain. Transition is a critical time for young adults with sickle cell and their communities. This includes the shift from pediatric to adult care, but also other life transitions, such as going on to college or finding a job. Parents, doctors, community health workers, and others all have a vital role to play in preparing and empowering young adults to take over the management of their disease. Next slide. So it's important to recognize that community health workers aren't addressing health and wellness in a vacuum, and that's where the social determinants of health come in. Individuals have their own genetics and health conditions, and they're interacting with the social and economic environment, which has tremendous influence on both individual and population level health outcomes, like life expectancy and disease progression. So questions that community health workers may be asking and may address are there factors in the community that build resiliency, like a strong sickle cell community-based organization? Or is there access to affordable medical services? Also, there's the broader social context to consider, such as are individuals and communities having experiences with racism and discrimination? Next slide. And so why community health workers? Well, they're incredibly effective because they understand the needs of the communities that they serve and how to build trusting relationships that can support all patients, including unaffiliated patients, in accessing care. They serve as liaisons or brokers between individuals and complex medical systems, complex social service systems, and information. Community health workers provide culturally competent care and disseminate information and link individuals to resources by building strength-based trusting relationships. Next slide. And just like individuals have their sets of strengths and challenges, so do communities. And these encompass some of the many social determinants of health, like, for example, the availability and accessibility of specialty care physicians and community-based organizations. For example, providing information on for example, community health workers can provide information on topics like accessing care through a medical home or a medical neighborhood. Next slide. A medical home is an approach to providing comprehensive care. In the case of sickle cell, we may think about it in the context of a medical neighborhood. Sickle cell specific, primary, and other care may not all occur under one roof, but the approach should be accessible, family-centered, community-based, integrated, compassionate, culturally competent, and also play a role in a young adult's preparation for transition. Next slide. So community health workers support individuals with sickle cell disease to access comprehensive care through interventions like education. CHWs customize information to make it linguistically appropriate, accessible, and digestible. They educate parents on various warning signs, like, for example, in an infant, swelling of the hands and feet. CHWs should also educate parents on all the available treatment options, including bone marrow transplant. Later on in a young adult's life, the community health worker may work one-on-one with young adults or the entire family to support a process that builds skills for transitioning to adult care. Next slide. CHWs also link individuals to other support services like a sickle cell community-based organization, camps, transportation, and also peer mentoring, which has proven to be a very effective intervention for youth in transition. Community health workers can also advocate by identifying both formal and informal partnerships and engaging in advocacy on the individual level. Next slide. So motivational interviewing is a tool that could be used to support individuals living with sickle cell disease to overcome barriers like adherence to a hydroxyurea prescription. It is a collaborative, relationship-based approach to behavior change that recognizes the importance of self-efficacy throughout the entire process. To understand behavior change in the context of health, it's important to spend a few moments on the trans-theoretical model, which many of you may have heard of. It's also called the stages of change, and those stages are pre-contemplation, contemplation, preparation, action, and maintenance. Next slide. Motivational interviewing is a tool that acknowledges most people are ambivalent about change, even when intellectually we understand that change could be a good thing for us. It's a process that recognizes a person's freedom to make their own decisions. It also provides community health workers with strategies to address sustained talk. And sustained talk is basically all the reasons a person perceives they can't change their behavior. In motivational interviewing, a CHW uses active listening and open-ended questions to demonstrate empathy and explore readiness to try a new approach. Instead of directing the person to take action, the CHW uses techniques like scaling questions to see where the person is and their willingness to maybe even learn more about a specific resource or behavior. Ultimately, the process will evoke or should evoke the person's own motivators to change. Next slide. So as I mentioned at the beginning of the presentation, HRSA funds 2 sickle cell programs, and this one specifically uses community health workers. It's the Newborn Screening and Follow-Up Program. The grantee for the Newborn Screening and Follow-Up Program is the Sickle Cell Disease Association of America, and they provide TA to support community-based organizations to improve the care of individuals with sickle cell disease and sickle cell trait identified through newborn screening. In this program, the community health workers provide training, community outreach, care coordination, referrals, and linkages to peer mentoring opportunities. Next slide. The second program is the Sickle Cell Disease Treatment Demonstration Program. And some of the the purpose of this program is to improve health outcomes in individuals with sickle cell disease and reduce the number of individuals who are only accessing care in the emergency department. Next slide. So this map shows the 5 funded regions of the treatment demonstration program, and the diamonds represent the community-based organizations who are sub-award recipients of the newborn screening and follow-up program. So it just kind of shows how we're trying to implement these programs on a national level. Thank you very much.
Thank you, Mia, for that excellent overview of sickle cell disease and for outlining specific ways that community health workers can assist with coordinating the care of sickle cell patients. Our second speaker is Dr. Mary Ciccarelli. She's a clinical professor of medicine and pediatrics and associate chair for education and pediatrics at the Indiana University School of Medicine. Dr. Ciccarelli will focus more on the transition period for sickle cell disease and also discuss some of her experiences as a director of a transitional care facility in Indiana. Thank you, Dr. Ciccarelli.
Hi, everybody. This slide has a lot going on purpose, and what it's meant to show you is that there is a lot going on during the phase between ages 11 or 12 to 25 to 27. And we're going to take apart different pieces of this graphic and talk about them. Next slide. I work at the Center for Youth and Adults with Conditions of Childhood. It's our statewide Indiana Transition Consult Service. We're funded through Maternal Child Health Title V dollars, as well as the School of Medicine at Indiana University and our county health system, Eskenazi Health. And we do a comprehensive transdisciplinary assessment of youth who have complex transition needs and provide them with medical summaries and transition goals that are youth and family centered, and then care coordination support to help launch them into the next steps that they've decided they're ready for. Next slide. So just to say simply, what is healthcare transition? It's a deliberate process of moving an individual safely and seamlessly from the pediatric-oriented healthcare system to the adult-oriented healthcare system. And we use the metaphor of a bridge. The pediatric health system moves the person from the typical model of pediatric care up the ramp of introduction of self-management skills helps in providing across the bridge a safe transfer of care, a warm handshake, not a hot potato toss over a fence ideally. And then the adult healthcare system has to accept the person off the ramp, acculturating them into the adult healthcare system. And so both of these require a change in the typical behavior of both pediatric healthcare providers and adult healthcare providers. In the pediatric world, we typically focus on a model of care that I would describe as the best interest of the person by proxies. So that means that the child is acted upon by their parents as a proxy who serve as the decision makers, and all the pediatric health system providers interact with that family, paying attention to the fact that they expect that family to act in that child's best interest, and they may even usurp the parent's authority in circumstances where parents are not deemed to be acting in the child's best interest. So they have to move from that model that they know and practice well into the introduction of the autonomous model of adult care. And so in the adult world, we give each person the right and dignity to make their own choices and be autonomous and choose how they want to care for their health, how they want to live their lives. And we don't intervene in a person who makes a choice that might be different from ours because we afford them autonomy. The introduction of early self-management in the adolescent period feels uncomfortable to a lot of pediatricians because we have to allow room for a little bit of error and risk-taking and behavior changes that aren't as controlled and neat as the proxy model might feel. And then the adult providers, when they receive patients, are receiving somebody who's not quite well established in the autonomous model yet. Think about the typical 18 to 22-year-old, not actually quite fully developed cognitively, and we'll talk about that in a moment, as well as not used to being in charge of themselves and being held accountable in the long haul for their behaviors. So the adult providers have to figure out how to adjust to somebody who doesn't quite yet know how to play the game of adult healthcare. Next slide. So we've talked about the pediatric healthcare providers as stakeholders, and we've talked about the adult healthcare system providers as stakeholders. There's two other critically important groups in this process. The youth has to move from being a dependent person to develop skills, become an early adult, and then become an autonomous, interdependent adult who works well within a social support system rather than trying to function on an island, which none of us do well attempting. Social isolation usually isn't a good way to have adult life success. The family has to go from being in charge to taking some steps back or beginning to let go to a point where they're actually just barely holding the person up, to a point where they are in fact consultants to the autonomous adult. They might be invited consultants or actually uninvited consultants. So all four of these different stakeholders are standing in a position where things are changing. And so, as it was already mentioned, change for humans isn't always easy. So everybody has to get their moving parts going in the same direction for us to get kids safely across the bridge into adult life. Next slide. And we've already heard about the social determinants of health, and that's a critical component for every individual and youth as they move from one system to another. And if we think about the impact of the family and local community or microsystem on an individual, as well as their neighborhood and social services and the media, as well as the whole culture at large. And all of these play a factor in those four moving pieces, all moving as they need to get to successful adult life. There are some specific transition risks that are notable to mention, specifically for children with sickle cell disease. They are, as already was mentioned, a highly covered population by Medicaid. Because of the way every state has variance in how they move either from Medicaid to another insurance plan, but all children age out of their children's health insurance plan or CHIP or SCHIP. They have to know what in their state can they fit onto next. There might be Medicaid expansion that they might be eligible for based on their economics. They might have a program in their college, an insurance plan. They might be employed at a location that has coverage through an employer-based insurance plan, or they might need to go through the network, the governmental network. And all of those are opportunities for people to get lost. And as young adults aren't great at navigating this on their own, we really have to pay particular attention to when their insurance is going to change and how we get them whatever they next need. How do they do that functionally in your neighborhood? Another important thing about sickle cell disease is that there's an impact on the brain by this disease. And about 30% of transitioning youth have had some impact on their cognition from their sickle cell disease. That I don't mean to infer that they don't have capacity, but they might not be exactly at the same place as they were intrinsically at a younger age because of the effects of the disease. In addition, those who've experienced CNS events, strokes, need ongoing transfusions, and maintaining the complexity of getting regular transfusions in our health system is hard. It's a bigger barrier than just getting pill prescriptions filled. There's a described lower high school graduation rate in this population. Is that due to social determinants of health as well, or due to CNS impact, or due to burden of disease that keeps children out of school? It's probably some combination of all of those. And then there is also high rates of other comorbidities like asthma and depression in this population. Next page, please. So now I want to introduce you to the National Center for Healthcare Transition Improvement. Their website is gottransition.org, and they have created for us toolkits for different stakeholders in the process of healthcare transition. And these toolkits came out of work through a combination of the American Academy of Pediatrics, the American College of Physicians, and the American Academy of Family Practice. And the toolkits, there are 5 toolkits on their website. There's a toolkit for youth, young adults. There's a toolkit for parents as caregivers or family as caregivers. There's a toolkit for people who care for children in a healthcare setting, for those who care for adults in a healthcare setting, and then a 5th packet for providers who care for children and adults. So think about med-peds practices like myself, as well as family medicine practices. And in each of these 5 toolkits, whoever you are as one of the stakeholders, you need to know what your 6 core elements are. But then you have to have some consciousness about the fact that the other guys need to be taking care of their 6 core elements for everything to move together well. And to summarize the 6 elements briefly, number 1, you need a policy. A pediatric care policy would say something like, you're a child. While you're a child, we're going to treat you in this best interest proxy model. Of course, it uses much more patient-friendly language than this, but for the purpose of today's conversation, I'm talking quickly. And the adult policy would say, we get that you're a young adult and you're new to the game of adult healthcare. We'll help you acclimate. And then both toolkits have registries where we think about how we track and monitor and don't lose track of people in the handshake between the 2 health systems. Then we do some sort of readiness assessment for self-management skills and education that helps grow that person's skills. Then we use the assessments we've made to actually create a plan of how we're going to move the system forward. One example I've already given you is figuring out what insurance the person has and what insurance they're likely next eligible for and how are we going to get them there. The 5th core element is to actually have good information and communication to the person themselves. It's fascinating when we look at studies of young adults who've had illnesses from childhood. The frequency of young adults not knowing what happened to them in their health care is somewhere in the 30 to 40% range across many different diagnoses. So a young adult will present to see me and say, I had a surgery, see this scar? And I'll say, what surgery? And they'll say, I don't know, something. And that's an inadequate transfer of care, isn't it? I can't take care of somebody who had some surgery on their chest. I need to know exactly what they had. And so a medical summary both educates the person themselves as well as the person receiving them in care. And then there should be a shared plan of care so that all different members of the health team and the person and their social supports can share whatever information the adult wants to share with everyone else. But usually that means, what are we doing about maintaining my hemoglobin? What are we doing about maintaining my pain? What are we doing about taking care of my nutrition or my neurological needs, etc.? And how everybody can understand where we're at in that plan. That's what a shared plan of care is. And then the sixth core element is to make sure we've done everything else before we say we're done. Just reaching a certain age isn't a reason to believe that the person ought to be done. If the pre-work was never done, you might be 50 years old and still need some of this work done to help launch you forward with better health and better health care provision. Next slide. So in kayak, we've learned that we can think of children in 6 categories. The 81% who have no chronic illness but still need to move from pediatric to adult health services. The four major categories of youth with a chronic illness: those who have a chronic illness without a visible disability, those who have physical disabilities, those who have intellectual disabilities, and those who have serious mental illness. And then there's the 0.05 or 1% who are highly complex. And what we've learned in kayak is that you're highly complex if you have 3 or 4 of these conditions. So let's say you have a chronic illness like sickle cell disease, and you had a stroke, so you have pronounced weakness on one half of your body, and you have a cognitive injury from that stroke as well, so you're not as capable to do reasoning for yourself as a fully neurotypical person would be, and you have significant depression. That would be a description of a person who is highly complex from a transition need perspective. Next slide. So I already think I said enough about this. 81% of youth don't have chronic illnesses, so they need regular health care as an adolescent with health education and appropriate screening and counseling about risk avoidance and reproductive health. They need health insurance. They need to know who their point of contact is in the health system. Ideally, we don't ever want people's primary point of contact in the health system to be an emergency department. Emergency department's job is to assess them for an emergency and get the person to whatever the next disposition is, not to actually manage in a comprehensive manner their health needs. So we want to make sure we're identifying a primary care provider. We have to help the person recognize when they are assuming the role as their own decision maker from a legal perspective, and have some information on how to functionally navigate the health system. Next slide. I remember we were talking about change. This slide, I think, is a good representation about how the different stakeholders feel before transfer. They like the pediatric healthcare world. They feel safe there. They feel cared for and nurtured there. And the thought of having to make a change starts to feel uncomfortable. And so during that transfer process, you're ending relationships that have been long-standing. The unknown is unclear to you. You don't really understand why you have to do that. Parents who are very invested in keeping their children alive and well all of a sudden have to step back and allow the child to perhaps even make some errors in their healthcare. And then when you look just a little further down the path, the different persons and stakeholders say, wait a minute, actually, I am an adult, and I do like getting adult health care treated as an adult rather than still receiving care at a children's hospital where there are pictures of elephants on the walls and the chairs are very small. And so it is important for us to recognize that during the transfer process, everybody's going to feel uneasy and need supports. Next slide. So how are we doing? We could be doing better. This is the one of the more recent assessments of how well we're handling transition in the U.S. Greg Sawicki in Boston uses a tool called the ADAPT, or the Adolescent Assessment of Preparation for Transition. It's a 26-item instrument. A score of 100% would mean people were well prepared. And when looking at a large cohort of Medicaid youth ages 16 to 17, they got about half as much information on their prescription medicines as we would have liked them to have. They got a third about as much discussion about motivational interviewing and self-management and health system navigation that you were already talking about a little bit, and they got very little transfer planning of at what age are we going to move from this doc to this doc, from this hospital to this hospital, from this counselor to that counselor. Interestingly, there was not significant difference in this study by which Medicaid plan you were in, what your gender was, or your diagnosis of chronic disease. So we have work to do in improvement. Therefore, we got to be talking to everybody, so we all up our game. Next slide. I mentioned already that youth in their 18 to 22 age range are not fully formed from a brain perspective. We know that the prefrontal cortex and the corpus callosum continue to grow and age till about age 25. And I have to tell you, as a clinician, I can see when it happens. There are patients I meet between the ages of 25 to 27 who are suddenly much better at navigating the health system, adhering to their own treatment plans, being invested in their own care needs. And when I ask questions like, how come you're doing everything I asked you to do now and you weren't last year? The most common answer I get back is, I decided it was time to do it. And it's not that I didn't have the health services I needed last year. It's that I still wasn't able to fully function in the autonomous, self-managing adult manner till my brain fully formed, which means that we need scaffolding for youth from 12 through 25 to successfully manage the specific needs and neurodevelopment of teens and young adults. Next slide. So what are some of the unique issues? We heard a little bit about non-adherence to treatment plans already. What are some of the specific issues about being a youth that impact differently how they feel about taking care of their health as compared to a typical adult? Well, let's just review quickly typical adults. We know that having a good, trusting relationship with your healthcare providers or your community health workers helps with people taking better care of their health. We know that your social supports matter and your stressors matter and how healthy you just are at this moment from both a physical and a mental health perspective, how easy it is to access health systems, what your health beliefs and health literacy are. We know that there are certainly specific problems with adherence caused by people who have serious mental illness or cognitive dysfunction or substance abuse as the ones that are really notable, but there's lots of other determinants of health that I've mentioned that can be factors in individuals' non-adherence. Now let's look separately at teens. So teens are going through some interesting processes at the same time as we're asking them to take over their own health care. Number one, they're developing something we call metacognition. When you're 3 years old or 8 years old, you don't have the capacity to look in the mirror and say, gee, why did this happen to me? That's just not how your brain works yet. It's somewhere around age 15, 16, where you can look in the mirror and ask and think about thinking. Ask the why behind what's happening to you. And when that happens, that shakes youth's attitudes towards their chronic disease. And they say things to me like, I hate my diabetes because I don't really want to have it. Why me? And that denial and hatred of your personal state gets in the way of self-care. In addition, the way the teen to parent relationship by definition has to have some friction during adolescence as youth are attempting to achieve independence and break free. And so then the parent chasing the child around with their medicines adds to some of that teen-parent conflict. There's also a need to develop one's own self-image and look at others and see oneself as the same as others in your peer group. And if you have a chronic illness, certainly more so if you have a physical, visible disability, that sense of self and normalization gets jeopardized. And then, of course, we also change longstanding health providers who we trust in. So all of these play a role in barriers to effective self-management that we have to address in this age group. Next slide. So what are the social things we want kids going through sickle cell disease transition to deal with? We want them to be able to start to talk to the doctor themselves, encouraging them to do this, initially with their caregiver present, but as they get older on their own. We want to begin to teach about tools for self-management. Maybe you need a pill box. Maybe you need an app on your phone that says time to take your medicine. What could you do that would help you with supports that isn't just your mother saying, do it, do it, do it, because that doesn't work well with 17-year-olds. You need a calendar. You need to know how to use the pharmacy. You need to know what's sick enough to need to come to the doctor, and you need to know what's my health insurance status. Next slide. Here's just a couple of examples of some of the self-management apps that some of my patients use to help them with remembering about their own care needs. Next slide. This is a transition readiness assessment tool published by David Wood, Greg Sawicki, John Rice, et al. And you can use this as a screener with youth. The access, how to access the tool is listed there as a link. You can score individuals a score between 20 and 100 on this instrument. I don't know how to make an appointment. I always do this for myself already. If you always do it for yourself, you would get a score of 5. If you don't know how to do it at all, you'd get a score of 1. And the scores we get on this help us predict what the person thinks of their own ability to self-manage themselves. It's also a useful tool when you're talking to the next person in a handoff, saying this person seems very ready and isn't going to need a lot of supports, or this person is still relatively early in developing these skills, even though they're old enough to move and need therefore more scaffolding. Next slide. What do we need to educate youth about with sickle cell disease in the transition? What kind of sickle cell disease they have, meaning SS disease or SC disease, etc. What their current management shared plan of care is that I've already mentioned. What can they do from a preventive strategy to prevent pain syndrome? Staying well hydrated in particular is so important, as was already mentioned. How do they handle a fever when it happens? What are early warning signs of a stroke? Who is their health team and how are they contacted? What do they know about their medical history and how are they recording that so they have it on hand? Next slide. And then what do they need to do from expectancy of what kind of healthcare do I still need to get? Well, you need to be going every year for an eye exam and a dental exam, and then have to have heart and lung and kidney and brain follow-up. Somebody has to be checking your immunization status. As you get into that reproductive period, genetic counseling about yourself and your potential partner and what your choices are as in regards to having children of your own. And then very importantly, the assessment at age 17 and a half or so of the person's cognitive ability and ability to make independent decisions and serve as their own legal decision maker. Next slide. So we've talked a little bit about what a safe transfer of care that happens now at the 18 to 22 age range, a sender and receiver both communicating with each other with good medical passport information and a graduation celebratory visit from pediatrics. It's not a sad goodbye that you've survived and are now adult. It's a successful graduation and should be lauded as such. And then the introductory visit on the new side with a little bit more work on how do we do things here? What do you need to be successful now as an adult? It is also important for people to know between that last visit and that first visit, who do I call should something happen during that period? Typically, that would still be the person you were leaving rather than the new person who hasn't met you yet. Next slide. This is just a representation of a shared plan of care that I mentioned already that would say things like, for my lung disease, my current goal is that I should be able to breathe freely and easily and do some regular exercise all the time. And if there's something that gets in the way of that, it might be some pain or coughing or shortness of breath. And if that happens, this is what I'm supposed to do. And what I do to actually stay well is a list of things like take my hydroxyurea as an example. And then what would be actually the emergency symptoms that would be a good reason to call an ambulance. Next slide. At IU, we have, in our summary documents, we have little passports that are related to people's specific health conditions too, like sickle cell. And this is just a representation example of the information you might want to make sure that a youth knows about themselves in regards to their sickle cell, as well as information that's being transferred to the receiving healthcare teams, both primary care and hematology. Next slide. I think I'm up to questions. Thanks for your attention.
Thank you, Dr. Ciccarelli. That's very interesting. It's helpful to know that there are so many tools available to help patients, providers, and families with the transition process. So at this point, we will go over some of the federal sickle cell disease resources, and then we'll have about 5 to 10 minutes for questions. So there are many federal agencies that work on sickle cell disease. I mentioned the Office of Minority Health, where I work. We have several resources now that are newly developed for Sickle Cell Awareness Month. NIH, also National Institutes of Health, has a new Cure Sickle Cell initiative, which was launched last week. And there are many excellent resources on that website, as well as their ongoing sickle cell disease information and resources page. Next slide. We also have the Agency for Healthcare Research and Quality. Tends to be more of a data-associated organization. And then the Office of Disease Prevention and Health Promotion has a lot of good resources on newborn screening, as well as with the CDC, also has information on sickle cell disease as well. Next slide. And the U.S. Food and Drug Administration has several resources on new treatments for sickle cell disease. Mia mentioned Endari, which was recently approved, and as well as some other drugs. Next slide. Mia and Dr. Ciccarelli both mentioned HRSA and the Transition website, which is supported by HRSA. And that is where many of the toolkits are available that Dr. Ciccarelli mentioned. And then again, CDC has a page specifically on transitional care. Next slide. And so all those resource links can be available if you go to the Office of Minority Health webpage. If you just Google Office of Minority Health and Sickle Cell, you should be able to find that page. Or you can send a note to the organizers and they'd be happy to share you the direct links. I encourage all of you to continue to send questions via chat. I'll go ahead and try to get through as many as I can. The first question is for Dr. Ciccarelli. Do you have any advice on effective ways to advocate for a change of care facility? And the participant has a specific scenario where they have a child with sickle cell. They started to do the transition process in the late teens with hematologists. They thought they had an adult provider picked out. When the child turned 21, the insurance made them go to another facility, and it was not who they had discussions with about transition. How can they advocate best for their child in this situation?
With the current system of healthcare that we have in the United States, insurance is your portal to access. If in fact you are in a Medicaid plan, and it has a preferred provider in one system and not the one you wish, there's likely a different Medicaid plan that you could move into that would have that other person as a provider. And usually Medicaid plans have some allowances for changing your plan for this reason. So that would be the first thing to investigate in this particular circumstance. That certainly happens in our state. The other piece would be if the provider you wanted to go to could enroll in this plan. So it depends upon what kind of managed plan or preferred provider insurance coverage you have. Some providers aren't in all plans and would be willing to do it if asked, and others are issues of how you've been either auto-assigned through your Medicaid or chosen not understanding the system of care you wanted to go to and have to move.
Okay, thank you very much. Another question for Dr. Ciccarelli. Are there resources available for the undocumented population when it comes time for transition to adult care?
So this is a political question and not a healthcare question. In the United States, we don't provide as a general rule, healthcare coverage for people who we don't have documentation for in adulthood, whereas we do in childhood. And so children fall off care as they age. And so that plan can, there are a number of ways to help families like this. Federally qualified health centers will have sliding scales, and where services can be less expensive. Some pharma companies or drug companies have special plans that you can apply for to get drugs at reduced cost. Critical access hospitals have some sort of resources. There are even some pro bono healthcare plans in certain jurisdictions through state or local medical societies. So this is a very regional question, and you have to know my answer to people who live in Allen County, Indiana versus Marion County, Indiana is very different. And we use a variety of all the things I mentioned.
Thank you. Next question is for Mia. Where can community health workers work?
So that's a really good question, and it depends on your level of training and also your area of expertise. So community-based organizations are one type of organization that CHWs often get their foot into the door. In the case of sickle cell CBOs, they're disease-specific. But there are also other types of settings where community health workers work, and that can include hospitals, federally qualified health centers. They can also be employed by nonprofits, for example, that are working in the area of lead prevention. So there's very diverse opportunities, and they can really cover the gamut in terms of the various health conditions.
And then a related question for Dr. Ciccarelli. Does your center currently partner with community health workers to aid in transitional care? And if so, what has worked?
We work with community health workers that work at our a number of community health centers, and also through a number of community-based organizations. We base our collaboration there if it's for a youth, it's because the family desires that support, and if it's for an adult, it's because the adult desires that support. So of course they give permission, and generally how we ask families and young adults how they want to get the help they're going to need in life. It might be through a computer site, it might be through videos, it might be through one-on-one supports of a community worker, it might be from being in a peer-based group of some sort. Those are all of the types of options to enhance people's education and comfort in caring for themselves that we offer.
Thank you. I think we probably have time for one or two more questions. So this next question is for Dr. Ciccarelli. What do you do when children don't meet the milestones for transition?
Well, if a person isn't meeting the milestones for transition, I think often we fail to check what the person's neurocognitive and mental health state is, and whether there are any specific barriers there that might be getting in the way of them serving themselves best, and therefore mean that they need additional supports. And so if, for example, a person isn't learning how to take care of a health condition on their own and not showing independence in terms of taking their medicines, figuring out what the cause is. Non-adherence is a symptom, not a diagnosis. Non-adherence means something's getting in the way, and then the question is, what is that something, and what are we going to do about that something? So is it get them mental health services? Is it keeping better scaffolding on board for the person? I often say to the 18-year-old who's still in high school, for example. So the average 18-year-old who still is in high school is not good at self-management. And if you say to them, are you doing a good job taking care of yourself? They will almost always say, not really. And so then I follow that with, so who could we get to help you? Would it be a friend? Would it be a parent? Would it be a sibling? Who is it that we could get to help you till you're better at doing this on your own? And when you present it in that manner, most youth will agree that having some form of scaffolding support is right for right now. Being 27 and not ready to be in the adult world isn't a reason to still get your care in a children's hospital. It's a reason to have better scaffolding in the adult world.
I think that's the last question that we'll have time for. I want to thank again all the participants for attending this webinar. I hope this was very valuable for you. Again, we hope to have our Office of Minority Health to host 2 or 3 other webinars in the next 6 to 9 months, so please stay tuned. Thank you again for everyone's participation, and thank you to Mia Morrison and for Dr. Ciccarelli for giving these excellent presentations.
Thanks so much, everyone.
Thank you.